Thank you very much, chairpersons, and thank you to Dr. Dhuru Shah for having me in this conference on PCOS. It's wonderful to see Anuja here. She's been the Rhodes Scholar from our batch. That's what I remember first about her. So it's really lovely to speak after you. Voltaire had said the art of medicine is to amuse the patient while nature cures the disease. And I think in PCOS this cannot be more apt because it is, as Anuja rightly put, the lifestyle that needs to be changed. And then we could do nothing, but lifestyle will make a dramatic difference in the outcome for this patient, both as an individual, as a mother, and even for the latter years of her life. There's another Zen saying which say we teach best of things we want to learn more, and this cannot be more true for me and my group who are massively interested in PCOS and implantation failures in PCOS. So when we look at the prevalence of PCOS, although the WHO states is the most common hormonal abnormality affecting 5 to 10% of the female population, I think in the last 2 decades, awareness and increased reporting have shown that the percentage is much, much more. As for the Indian data, we know the prevalence of PCOS in the Indian adolescent girls ranges and goes up to as high as 33 to 36%. And that is why it is extremely important that these girls are picked up early, made aware, because as Anuja said, it's very late to tell them about diet and lifestyle when they want to have a baby tomorrow, and it cannot be postponed. As we also know that insulin resistance is reported in almost 75% of the PCOS women in India, and hence I think it is very important that we know this and we look into it. So when we look at the phenotype-genotype relationship, we know that Central Asians have a high metabolic phenotype, which is insulin resistance, metabolic syndrome, type 2 diabetes and hypertension, whereas hyperandrogenic phenotype is common in other parts of the world, including the Europe. So when you have women who have got severe metabolic phenotype because of insulin resistance, this means they have almost 2.5 times more insulin release, 2 times high prevalence of cyst formation, 6 years advance in ovarian aging, and 16 times high incidence of gestational diabetes. And that is important that we look at insulin resistance, particularly in the Indian diaspora, because PCOS manifestations, as I said, of insulin resistance is not only hyperinsulinemia, hyperandrogenism, which will give them acne and hirsutism, metabolic syndrome, which will happen to them once they have finished their childbearing, and psychological problems, which we now are making ourselves and our colleagues aware that this needs to be looked into. When we look at customizing ovulation induction protocols, we look at these 2 Bibles and guidelines, the 2018 International Evidence-Based Guidelines for the Assessment and Management of PCOS, and the 2019, which is the Ovarian Stimulation by Estrogen. Why is it necessary to individualize or customize protocols? Because it is important that we do not have cycle cancellation because of poor response if you have started very low doses, or the opposite, which is hyper response or OHSS. Multiple pregnancies and its complications, I need not stress more. We all know that PCOS women are prone to this, and the clinical problems of hyperstimulation, increasing maternal perinatal morbidity and occasional maternal mortality. So individualizing or customizing the protocols gives us the maximum beneficial effect of looking at a singleton live birth at term. So the first drug that comes up to customized protocols would be metformin. We know it has actions on various different organs, liver giving you decreased gluconeogenesis, decreased lipogenesis, and increased glucose uptake. The pancreas, where it decreases insulin secretion. The endometrium, where it increases nitric oxide production, perhaps increasing the implantation rates. And at the ovarian level, where there is inhibition of sex steroid overproduction and premature luteinization by direct effects on the ovaries and decrease in the hyperinsulinemia. So metformin will improve insulin resistance, glucose tolerance, increase incidence of ovulation, menstrual cycle regulation, and give you weight loss. When we look at the other inositols, the myo-inositol is something that will work in synergy. It decreases free fatty acid release, increases adiponectin release, and will give us decreased insulin resistance. It also is known to improve oocyte quality and hence improves follicular maturation. So this synergy between metformin and myo-inositol will help us to get not only weight loss and decrease in the hyperinsulinemia, but will also get us better oocytes and fertilization rates. So when you look at treatment in PCOS, the first line of non-pharmacological treatment would be diet and exercise. As Dr. Dokras has said, OC pills prior to them wanting to go for infertility to reduce their hyperandrogenism. The first line of pharmacological treatment for infertility would be letrozole, that is the drug of choice, as against clomiphene, which has been used over the last 3 to 4 decades. The second line would be gonadotrophins, with or without agonist and antagonist, laparoscopic ovarian drilling in patients who have failed medical management or have history of hyperstimulation. And obviously the third line of treatment would be IVF with agonist, but now with antagon protocols. So when you want to customize the stimulation protocols, you look at different parameters or markers: age, FSH, AMH, and antral follicle count. And I think it is extremely important that if you combine AMH and antral follicle count, you get a better prognostic value to your patient than taking either or alone. Further, you will like to amend your protocol when you add BMI, because we know that is something which is going to affect. When you look at this comparative effectiveness of various treatment protocols, one that ranks first would be metformin, letrozole, and HMG stimulations in patients who have been classified as clomiphene resistance. Prerequisites for ovulation induction: it's very important to start the stimulation no later than second or third day, but you need to do a basal scan to rule out that there is no follicular cyst which is bigger than 10 mm. There is absence of any residual cyst from the previous cycle, and the endometrium is thinned out and is less than 6 millimeters. Letrozole, as I said, is a drug of choice. We all know how it is given. No adverse anti-estrogenic effect on the endometrium or the cervical mucus, particularly when you're planning planned relations as a treatment protocol. Rapid elimination, so it doesn't affect the endometrium as much, can be given to back-to-back cycles and has got better uterine blood flows, all which is absent in clomiphene citrate, and hence letrozole scores over clomiphene citrate as far as your pregnancy rates are concerned, as far as the live birth rate. So if you look at this paper, which is a double-blind randomized controlled trials of letrozole versus clomiphene in PCOS patients, it scores very well on all the parameters that we want, like pregnancy rates, live birth rates, pregnancies per cycle, and ovulations per cycle. You would need to add gonadotrophins to your oral ovulagens if you find that the recruitment has not taken place only with them, and you would add them around the 7th day, give it daily in low doses till you reach the day of trigger. Now there are low dose protocols which are used in IUI cycles. When you start with very low doses, you can either increase the doses by 100% when you after every 7 days, or by 50%, thereby ensuring that you do not land up with hyperstimulation, and as far as possible trying to have a monofollicular development, particularly in IUI cycles. Chronic low-dose protocols, which we have all used, can go on for almost 20 to 30 days. It reduces multiple follicular genesis, gives us good pregnancy rates of almost 45% in IUI cycles, but understand that the patient has to be well counseled that this treatment may go on for 25-30 days, and the cost implications is something that they need to know about. When you look at which gonadotrophin to use, we all know that there is no evidence in difference in live birth rates or hyperstimulation rates, be it urinary, be it highly purified, or even recombinant FSH. The evidence is low because we have got very low numbers, but again, as I said, we have to weigh the cost and the convenience, especially if you are going to use recombinant in IUI cycles. What about antagonists? Now, antagonists are available in India over the last 10 to 12 years. It flexibly suppresses LH in the follicular phase. It can, when you give an antagon cycle, you have the advantage of using agonist as trigger, freeze all cycle, and move towards an OHSS free clinic that we all want to do in patients with PCOS. Antagon is also used in IUI cycles, especially when you're using gonadotrophins, because 25% of your patients on gonadotrophins for IUI cycles will have a premature LH surge, and hence it is important that you add the antagon so that you ensure you do not land up with luteinized unruptured follicles. But what is the eye opener in all your ovulation induction patients? The IVF outcome in PCOS as compared to non-PCOS in long down-regulated IVF-ICSI cycles was not associated with difference in the oocyte morphology or the embryo quality or the metabolic activity of pre-implantation embryos. The outcome of high miscarriage is associated with BMI, and we come back again to that it is extremely important that we counsel these patients to have lifestyle changes to make sure that they lose weight, because for every one BMI that they lose, the odds will increase by 0.5, and for every BMI 1 that they increase, the odds of not getting pregnant increase by 1. So it is extremely important that patients are told that they lose weight. Crash diet doesn't work. They have to lose weight over a period of 3 to 6 months, and a very rough estimate would be 10% of weight loss. So lifestyle intervention is recommended first. Bariatric surgery, that is now we all talk about, is kept only for patients with BMI of more than 35 or those with comorbidities. Letrozole is the first line treatment. Metformin alone has limited benefits in improving live birth rates. Gonadotrophins and laparoscopic ovarian drilling can be used as second line. No clear evidence for efficacy of acupunctures or herbal mixtures. Those who do not improve with lifestyle and ovulation induction, IVF, particularly antagon protocol, is something that we should look at PCO patients. And metformin used in agonist cycles as an adjuvant will help us to reduce the risk of PCOS. Thank you very much for a patient hearing, and thank you once again to PCOS Society and Dr. Durusha for having me in their pre-Congress.